Hello everyone. I'm presenting a video of a challenging case of primary sheathless retrograde intrarenal surgery for 1.5 cm lower calyx stone in an unstented patient with autosomal dominant polycystic kidney disease. I have nothing to disclose. The objective is to demonstrate the feasibility and intraoperative challenges faced during RIRS in patient with Adpkd. The patient is a 50-year-old female who is presented with left flank pain on and off since 1 year. She is a known case of bilateral Adpkd. Her renal function test is normal. She was on ecosprin, which was stopped 5 days prior, and the urine culture is sterile. The patient has a left lower calyx 1.5 cm stone, and polycystic kidney disease is visible on the CT IVP. The plan is left RIRS with stenting, SOS, percutaneous nephrolithotomy. The challenges are the polycystic kidney disease, lower anterior calyx stone, difficult anatomy, difficult stone clearance, and the risk of bleeding, infection, cyst rupture, and renal damage associated with the polycystic kidney disease. To begin with the cystoscopy followed by ureteroscopy, exosheath was not able to pass as she was an unstented patient, hence we decided to go sheathless in this procedure. A disposable digital 7.5 French ureteroscope from the Biorad company was used for the procedure. As we can see, to begin with the RGP, the stone in the lower calyx is visible, and retrograde pyelography is done to evaluate the relation of the stone with the calyces. An acute angle is visible. The sheathless procedure, the disposable ureteroscope was passed over the sensor guide wire, and there was a kink in the upper ureter at the PUJ, which was negotiated with the help of the disposable scope and the guide wire. The stone in the lower calyx is visible, and it is being dusted with the help of the thulium fiber laser 35 watt, and 200 micron fiber is used for the procedure. The initial settings are 1 joule and 10 Hz. However, due to the cyst compression, there is an indentation of the pelvic arachal system over the endoscope, making the intrarenal movement of the scope difficult, and we can see the compression of the cyst over the scope, making a difficulty in pointing the laser onto the stone. Hence, the plan was to fragment the stone as much as possible in the lower calyx and then basket it into the favorable calyx. Due to the continued difficulty in pointing the laser onto the stone, now it will be basketed into the middle calyx. However, the stone kept becoming inaccessible due to the anatomy and different maneuvers such as the Mertz maneuver, such as pressing the anterior abdominal wall, changing the position to a head low or a head up position actually didn't work, and the stone didn't come into the center of the vision of the scope. Mild mucosal erosion due to the movement, brushing of the mucosa with the laser fiber, with the endoscope, and with the accessories such as basket produce a mild hematuria. We use general anesthesia for the procedure. Now the stone is being basketed. However, there is a difficulty in basketing the stone as well. We are using a 2.2 French Dormia basket. With difficulty, the stone will be basketed and shifted to a more favorable calyx. Gentle handheld irrigation with the 50 ml syringe is used during the procedure. Now the stone is being shifted to the middle calyx, expecting that this will be a favorable calyx. The stone in the middle calyx, however, is also not very feasible to point the laser onto the stone, and the stone keeps getting out of the view and keeps drifting to an unfavorable position where the scope and the laser is not really in center, and despite being in the middle calyx, the stone is not really in front of the laser, which was a surprise to us. Especially we need to avoid puncturing the cyst even with the laser, because that can cause infection and bleeding and rupture. So despite being in the middle calyx, the stone is not coming into the center of the field of vision. So the stone is now being basketed from the middle to the upper calyx, expecting that this will be the favorable calyx with relation to the scope and the laser. My assistant is now grabbing the stone with the Dormia basket and he is shifting it to the upper calyx. Here also the upper calyx has got a long infundibulum, hence the idea is to place it near the junction of the pelvis and the upper calyx so that it doesn't shift much to the infundibulum and to the minor calyces. The settings usually for fragmentation, I'm planning to dust the stone as much as possible. I don't want to fragment and grab the fragments because I'm not having an excess sheath with me. Gentle irrigation is being used to decrease intrapelvic pressure. However, the stone is getting pushed into the upper calyx, minor calyx, which has a long infundibulum. Mild hematuria and the dust is making my vision a little hazy. So I will be aspirating the stone dust in order to get a clear vision. After aspirating the stone dust, again the stone is getting into my vision, and I will be now dusting the stone with the thulium fiber laser. The settings usually are around 1.1 to 1.2 joules and frequency of around 10 to 15 hertz. The stone is now being popcorned with the laser settings of around 0.2 joules to 30 hertz, so that I produce a fine golden dust at the end of the procedure. Since I'm not having an excess sheath, I cannot grab the fragments, but I'm planning to have a complete golden dust at the end of my procedure. Complete clearance is visible on table with the help of fluoroscopy and retrograde pyrography, and I'm seeing no contrast extravasation suggestive of any fornicial rupture or any other complication. The total operative time was 2 hours with the laser time of 1 hour 15 minutes. Complete clearance was achieved in a single stage in an unstented patient. No rupture of the cyst or post-operative infection was noticed. The management of stone disease in polycystic kidney disease is always challenging because of the risk of renal failure, cyst rupture, bleeding and infection. Whatever be the option, either PCNL, ESWL or RIRS, it is challenging. However, RIRS is more challenging due to the risk of wear and tear of the endoscope. However, it has advantage with the released risk of bleeding, nephron loss, and it is safe and effective for most of our patients. Thank you.